Hello, everyone, and welcome to the symposium on the management of degenerative MR with TEER and evidence-based guide. My name is Tarun Chakravarty. I'm an interventional cardiologist at the Cedars-Sinai Heart Institute in Los Angeles, California, and I'm delighted to be chairing this session. The program has been created by Radcliffe Medical Education and supported by an unrestricted educational grant from Edwards Lifesciences. As a reminder, this is a CME accredited live program. PeerPoint Medical Education Institute is accredited by the Accreditation Council for CME, who have designated 0.75 credits to this activity. So please don't forget to claim your CME credit for this session by clicking on the button below the video player. We also encourage you to actively participate during this session. Submit your questions in the Q&A box under the video, and we look forward to addressing your questions at the end of the session. Now, the objectives of this session are to identify patients who are suitable for transcatheter repair over other treatments, recall the long-term clinical outcomes of mitral TEER in patients with degenerative MR, select the appropriate TEER device based on design features and clinical data, and review the different TEER implantation techniques. Now, I would like to start the session with a talk on transcatheter repair selection in degenerative MR. Okay, here are my slides. So the title of my talk is Transcatheter Repair Selection in Degenerative MR. Here are my disclosures. So mitral regurgitation is the most common valvular heart disease in the general population. Here's a population-based study that was published in The Lancet in 2006. Now, MR is divided into 4 categories based on the Carpentier classification. Type 1 being normal leaflet motion, Type 2 with increased leaflet motion due to prolapse or flail, Type 3A with restricted leaflet motion in systole and diastole, or Type 3B with restricted leaflet motion in systole. For the sake of this talk, we're going to focus on degenerative MR, which is Carpentier type 2 with leaflet prolapse or flail. Now, degenerative MR is a spectrum. It represents a spectrum starting with isolated fibroelastic deficiency that may present as a single caudal rupture to progressive myxomatous changes, eventually resulting in Barlow's valve with multi-segment prolapse, large valve, excess tissue, or thickened chordate. The degenerative MR prolapse leaflets, they are characterized histologically with a significant growth of the spongiosa layer in the prolapsing scallop. The resulting MR eventually leads to dilation of the left atrium and ventricle, fibrosis of the papillary muscles, and ruptured chordate. Now, DMR, degenerative MR, is common. In this population-based Framingham study of 3491 patients, mitral valve prolapse was noted in 2.4% of the population. Here's another population-based study that shows that Carpentier type 2, which is degenerative MR, is noted in almost 15,000 patients for every million population, estimating a prevalence of around 1.5% in the general population. Further, the prevalence of degenerative MR increases with age. As you see here, patients who are 80 years of older have the highest prevalence of degenerative MR in the overall patient population. And untreated MR has bad prognosis. When you look at the natural history of untreated MR, untreated severe MR will eventually lead to LV dilation, LV dysfunction, and onset of symptoms. Therefore, the optimal timing of surgery should be before the decompensated stage when irreversible damage to the left ventricle can happen. Now, isolated moderate or severe MR is bad. It's associated with worse outcomes. Here's the Olmsted County data of 1294 patients with isolated moderate or severe MR diagnosed during a 10-year period in the Olmsted County. The expected survival at 10 years in this population was close to 60%, whereas patients with isolated moderate to severe MR was noted to have a survival of around 30%, so almost half as much. So it's associated with bad outcomes. Here's a summary of the different population-based studies of degenerative MR with medical management. And the annual mortality in the population, depending on the study, ranged from 3% to as high as 9% in these studies. So the treatment options for degenerative MR include surgical mitral valve repair, or replacement, which is the primary treatment modality for degenerative MR in patients who are surgical candidates. Transcatheter mitral valve edge-to-edge repair, popularly known as mitral TEER, which is a treatment option for patients with primary MR and severe symptoms who are at a prohibitive risk for surgery. And transcatheter mitral valve replacement, which is in clinical trials as a treatment option for high surgical risk patients who are not optimal candidates for mitral TEER. Now, I would start off with this slide to make the point that surgical mitral valve repair has excellent outcomes. Here are 4 large series from high volume centers in the United States showing excellent outcomes over a 10-year period in terms of freedom from greater than 2+ MR. However, with the caveat, the echocardiographic follow-up in the surgical series has not been very good. So that's the limitation of these surgical series. The ACCME guidelines recommend surgery as a class 1 recommendation for patients who have symptomatic severe MR or patients who have severe MR with LV systolic dysfunction defined as LV ejection fraction 60% or less, or LV end systolic diameter 40 millimeter or greater, and mitral valve repair is preferred over replacement. However, mitral valve surgery is grossly underutilized for the treatment of MR. Here's another slide from the Olmsted County data where mitral valve surgery was performed in only 13% of patients with isolated moderate to severe or severe MR, and only 29% of patients with primary MR underwent surgery. Here's data from the STS registry that shows only 30,000 to 40,000 patients in the United States undergo mitral valve surgery, despite 2.5 million patients diagnosed with MR annually. So, the ACCME guidelines now recommend mitral TEER as a class 2A recommendation, level of evidence B, for patients who have symptomatic primary MR, who are at high or prohibitive risk for surgery, who have anatomy favorable for transcatheter approach and a life expectancy of at least 1 year to meet this, to address this unmet need. There are currently 2 available mitral TEER devices, the MitralClip G4 system as well as the Pascal system. In the United States, as of 2019, the mitral TEER volume has already exceeded the surgical repair volume. If you look here over an 8-year period, the surgical volumes have almost remained unchanged, if not decreased slightly, whereas the mitral TEER volumes have progressively gone up, and they continue to go up in the United States. Now, we are lacking good quality randomized data of mitral TEER versus surgery for degenerative MR. There are 3 ongoing randomized trials. The primary trial that is randomizing patients with DMR to mitral TEER versus surgery in all patients who are over 60 years of age. Repair MR that is randomizing patients to mitral TEER versus surgery who are at moderate risk for surgery, and the MITRA HR study that is randomizing DMR high-risk patients to mitral TEER versus surgery. So over the next several years, we'll have actually good quality evidence to guide us better in terms of different treatment options. In terms of patient selection for TEER, these patients are divided into 3 categories: straightforward TEER anatomy, the green patients, yellow patients with complex TEER anatomy, or red patients with prohibitively complex TEER anatomy. The green patients, these are A2, P2 pathology, relatively narrow prolapse or flail, mitral valve orifice area of greater than 4 centimeters squared, or LVEF of greater than 25 to 30%, whereas complex TEER anatomy includes commissural disease, multiple regurgitant jets, non-significant cleft and grasping zone, MAC without leaflet extension, small mitral valve orifice, or failed surgical mitral valve repair. And I have to say, these are the patients that we frequently see in our practice. And then the prohibitively complex TEER anatomy includes severe MAC with mitral stenosis, leaflet perforation, wide coaptation gap, calcified leaflets or rheumatic valve, or cleft leaflets in the grasping zone. Now, for patients with straightforward TEER anatomy, mitral TEER is the best solution. For patients with complex TEER anatomy, complex mitral TEER is still one of the best available solution. However, in select cases, transcatheter mitral valve replacement may be considered in trials. And patients with prohibitively complex TEER anatomy, transcatheter mitral valve replacement in clinical trials seems to be the best treatment option. So with that, I will conclude my talk to summarize that degenerative MR is common. Surgical outcomes for degenerative MR are excellent, but patients with DMR are undertreated with surgery. Transcatheter mitral valve edge-to-edge repair is an alternative to surgery for symptomatic patients with DMR who are at high or prohibitive risk for surgery, and it's actually recommended by the ACCEHA guidelines as well as a Class 2A indication. The ongoing randomized clinical trials are evaluating the safety and effectiveness of mitral TEER in low-risk patients with degenerative MR. And transcatheter mitral valve replacement is an option for high-risk patients with symptomatic degenerative MR who are not good candidates for mitral TEER. Thank you. Okay, great. So at this point, I will introduce our panel. It's with great pleasure and honor that I'm joined today by two fantastic experts. Dr. Firas Zahr from Oregon Health and Science University, Portland, US. And Dr. Tom.
So happy to be with you.
And Dr. Tom Cahill from University of Oxford in the UK.
Hi there, great to be here.
Perfect. Now, without further delay, I will now pass the word to Firas, who will be presenting on making evidence-based decisions in TEER, insights from recent clinical data. Over to you, Firas.
Thank you, Tarun. That was a fantastic presentation. I learned quite a bit myself. This is my disclosure slides. And, I really want to emphasize and summarize what Tarun said. We all feel that this is our current practice in the United States, that those who are low surgical risk or suitable for surgery are being treated by surgery for DMR. And again, I want to emphasize, that the talk today is focused on DMR, not FMR. Now, if we look at the suitability for TEER, the spectrum from those who are not suitable to those who are green and very suitable. And I think we're seeing all of those patients in our practice. So if we look at what we need from TEER, we need it to be safe and effective treatment for mitral regurgitation. However, there are still potential challenges, that suggest that we need to take a deeper dive into suitability, efficacy, as well as treatment durability. And I will focus on those in my talk. So if we look at that Class 2D trial, and I will I'd like to highlight that trial because it was a randomized trial. It took patients who were suitable for both MitraClip and Pascal and randomized them to 2-to-1 fashion, MitraClip Pascal. But those who are not suitable, i.e. the yellow category, were treated with the registry and followed with the registry with the Pascal system. The trial was randomized. This is the inclusion and the exclusion criteria. And what Tarun has outlined as anatomically complex patients, those who were treated in the registry. This is the baseline characteristics, sick patients with multiple comorbidities. And if we look at the MR reduction, you will see that the MR reduction is to 2+ or less. It is over 90%, for both devices, MitraClip as well as Pascal. It's almost 93, 94%. But even if we take the bar higher and we say we're looking at MR of 1+ or less, that was achieved with, high rate, 78% with the Pascal and 68% with the MitraClip. And again, the study was not powered to look at what device is superior. This is a non-inferiority trials, and it was not designed for superiority. However, if you look at the green, light and dark green, if you wish, which is MR 1+ or 2+, and you look at it 30 days, 1 year, 2 years, you see in both MitraClip and Pascal that the results are durable. And so far, we have the 2-year results of the randomized trial, and we anticipate longer follow-up data to come in the next couple of years. So the acutely achieved results appear to be durable at least up to 2 years. Now, that is associated with favorable gradient. The gradients were not increased with neither MitraClip or the Pascal, improved LV hemodynamic, as well as quality of life and New York Heart Class Association for patients treated with TEER. The recurrence event for mitral valve reintervention has been low. So it is not like patients are getting surgery for after TEER. And also the mortality, all-cause mortality and cardiovascular and hospitalization was low in both groups. Now, if we switch a little bit to the registry, And we will see the registry included all of those complex patients. It was probably a little bit sicker cohort patients from, the randomized arm, and followed those again to 2 years. You'll see that the reduction to MR, 2+ or less, is also achieved with high prevalence, is over 90%, similar to what we've seen in the randomized arm. However, the 1+ or less, as expected in the more complex anatomy, was achieved, to 67, 68%, and a little bit lower than the randomized arm, as indicative with the complex anatomy. But yet, those who receive good results and reduce their MR to 1+ or 2+ or less, they were sustainable up to 2 years. So really, we are seeing a longer-term data that suggests improvement in MR, sustainability of that, as well as good gradients and favorable remodeling of the left ventricle, and improvement in New York Heart Class Association and quality of life. So where we are today is, we have long-term data. I showed you the 2-year data from a randomized trial, MitraClip versus Pascal, and again, it shows, the Everest 5-year results data, and we have gotten better in terms of, 1, choosing patients, 2, get adequate results, and we are showing that those who receive good results, those results appear to be sustainable. So on the MitraClip side, and simultaneously, there was an expand G4 registry that is going on, and the expand G4 registry have done exactly what you see in real life, which is, what are we treating with TEER? And it shows that only 26% of what we are treated is considered, quote unquote, suitable for TEER, and the rest of what we are treating is actually complex anatomy. So the data is moving towards, whether with the Class 2D registry or the expand registry, it is showing that we are all treating more complex anatomy with TEER, and we are achieving good and durable results. So, to put everything together, and I overlap the data with what we have in terms of the spectrum. So the more complex anatomy, we have shown that, yes, we are receiving good results, and results are durable, but is not it is not as high as you achieve with a straightforward TEER anatomy, where the MR reduction to 2+ or less is achieved in 90%, plus of the time. Nonetheless, the MR reduction, the durability of the results, as well as the improvement in LV hemodynamics and quality of life, are really positive sign to support the use of TEER and the durability of that therapy. So if we put all of the data, together, and from all of the trials that has been, completed so far, and I want to agree with, Tarun, that the ongoing, trials will help us understand. But there is a really large patient population that is treated with TEER, that we follow the results, and it shows that the MR reduction of 1+ or less is achieved in 90%, plus, and 2+ or less is achieved in 90% or more of the patients. So what is happening with those who do not achieve the results? And I want to put this into perspective, because again, this is data looking at the patients who have not achieved, good outcome, and you will see that the median reintervention time is short, is within 4 months, indicating that those who did not receive, good outcomes, those good outcomes are identified early and then intervening on early, and mostly by either redo TEER or mitral valve replacement. So in a way, if we achieve good acute results, past the first 30 days or 6 months, then those results are durable and sustainable. And again, if you look at our reintervention rate, it has been stable over the years from 2014 to, in this paper, up to 2017 that looked at, and despite the fact that we're treating more complex anatomy. So to conclude, we have 2 years data from Class 2D, randomized, and registry. We have longer data from MitraClip, and they all confirm that the repair is the durability, sustainable, and treat broad patient population with DMR. And Across all what we're treating with TEER today, we have demonstrated favorable survival, robust and sustained MR reduction, significant and durable ventricular remodeling, as well as improvement in quality of life and functional status. Thank you very much.
Thank you, Firas. That was excellent overview of the outcome summary. And at this point, before we discuss further, Tom will give a short presentation on technical considerations for TEER and DMR patients. So over to you, Tom. Thank you.
Okay, thank you very much for the introduction. So we've heard already now a little bit about suitable patients and how to identify them for transcatheter repair. We've talked about some of the long-term clinical outcomes for TEER in patients with DMR. And I'm going to talk more about selecting TEER devices based on design features and valve pathology, and perhaps some tips and tricks for TEER implantation. So as we've already heard, there are two commercially available TEER devices available in the US and Europe, the MitraClip device from Abbott and the Pascal Precision device from Edwards Lifesciences. Both are mother and child catheter devices for accessing the left atrium, steering down to the mitral valve, and delivering devices to achieve edge-to-edge repair. There are important differences between them that are worth highlighting. MitraClip is a 2-catheter system. Pascal Precision is a 3-catheter system, which gives you some additional flexibility in steering planes in some complex anatomies. As we've heard, the MitraClip has 4 devices, Pascal 2 different sizes. The closure mechanisms are different, and that has some implications. So MitraClip is an active closure system, Pascal is passive, and that means that there's a slight difference in the leaflet tension that you achieve, and that may be desirable, undesirable, depending on the pathology you're looking to treat. MitraClip is a slightly stiffer device, and what that means is you're not going to get buffeted around so much by the valve, but conversely, it's slightly easier to store up tension in the MitraClip system without realizing. Pascal is a slightly more flexible system. And as I'll show you in a moment with one of the cases, Pascal allows for device elongation, which can be useful for commissural pathology and slightly reduces the likelihood of getting caught in the subvalvular apparatus. So I won't labor this again. We've seen this already. MitraClip has 4 devices, 2 lengths, 2 widths. Pascal has 2 devices. Perhaps I would just highlight the Pascal P10 device, which has a unique central spacer device. And the aim of that is to try to reduce the tension on the leaflets. And my personal practice is to use that increasingly in functional valve disease, which we're not talking about today. But it's a nice adjunct to be able to have where you're worried about leaflet tension causing problems. Following on from Firas's data review, I thought I'd just highlight this meta-analysis of observational comparative studies between MitraClip and Pascal. Again, it's all observational, but it's 1,500 patients with a mean age of 77, over half men, just under half DMR, with the vast majority grade 3 to 4 MR and very symptomatic patient cohorts. There was no significant difference in procedural success between the MitraClip and Pascal device, and just a slight trend towards not achieving MR grade less than or equal to 1 in the MitraClip arm, with a risk ratio of 1.2. But importantly, with the caveat that this is observational data, it's likely not adjusted for differences in the 2 arms, and there's quite a lot of study heterogeneity. No differences in mean gradient, no differences in the rate of SLDA. So coming on to device selection, we've seen this kind of paradigm of valve complexity already. What are the sort of complex lesions particularly occurring in DMR? Well, commissural lesions for sure. Annular calcium, where that calcium extends onto the leaflet. Wide jets or multi-segment pathology. Barlow's disease, where there's very extensive degenerative disease of the whole anterior and posterior leaflets. Clefts are difficult. And these factors then, in turn, may inform our device choice or our clip sizing approach. So how do we make those decisions? Well, we've talked about anatomical complexity of the valve at 9 o'clock, but the other considerations are going to be leaflet tension. And again, if you want leaflet tension, for example, if you're really looking for a good annuloplasty effect, then my personal view is that MitraClip gives you a really good hold of the leaflets. But you need to be thinking also about jet number, width, and location. How many devices are you thinking you're going to need, and where are they going to be deployed? And in turn, that informs what size of device and where are you going to put them. Baseline gradient and baseline mitral valve area are worth considering together because they both tell you something about how much space you've got to play with. If you've got a small valve, 3.5 centimeters squared, you might be looking at a one and done case. And that means you're going to need to think very carefully about where you're going to put that one device and also the size of device you're going to choose. And perhaps MitraClip gives you a little more flexibility about your sizing device strategy. Annular and leaflet calcification, we already highlighted as part of the valve pathology complexity issue. I worry that if you've got leaflet calcium, the whole system the whole leaflet system is stiffer. Perhaps there's a slightly higher propensity to tearing or injuring the leaflets. And for that reason, I like Pascal in that system because I think you transmit a little less force to the valve leaflets. And then, of course, your procedural strategy. Which direction are you working? What are you trying to achieve with each device, first and subsequent? So in this last segment, just a few tips for success. I'm sure many of these will be familiar to TEER operators. The first, get your transeptal right. For DMR, we're looking for a height above the mitral annulus of 4.5 centimeters. At the moment, this is too low. We need to clock our transeptal system. And what you can see is what we achieve with a little clockwise rotation is now a height of 4.1 centimeters above the valve. That's going to give us much more play around the valve. We're going to be able to access all segments of the valve. It's going to be much easier to come to the medial aspect of the valve, and it's going to mean that we can come up above the valve nicely to reorientate if needs be. Second, respect the valve plane and the coaptation line. What does that mean? Well, it means that we don't want to cinch up the valve with our device in any way that distorts the native anatomy. We want to focus on the segment we're treating and be cautious about how we deploy those devices. So we want to make sure our trajectories are right. We want to be entering the valve perpendicular to the annular plane, both in the medial lateral trajectory and in the AP trajectory. And one of the key things we can change if things don't look quite right with TEER is adjusting our trajectories and making sure we're perpendicular to the annular plane. What about the coaptation line? Of course, there's this smile we're used to seeing across the medial to lateral commissure. And depending on which segment of the valve we're treating, we may want to rotate the devices differently in order to be perpendicular to the coaptation line. Third, where it's possible, I think we should be looking to control the pathology. This is a diagram from our surgical friends and partners performing a quadrangular resection. And of course, the basis of mitral valve surgery is to isolate and control the pathological disease segments. We can't always do that with TEER because we're limited by valve area. But where we can do it, I think it means we're likely to get a more durable result. This is a recent case of ours in Oxford where there's very extensive posterior segment disease all the way through P2 into P3. Now, fortunately, the starting valve area here was very big, almost 10 centimeters squared. So even after 2 devices with good reduction of MR, you can see there's a big lateral prolapsing segment. And without treating that, there's a potential nidus for recurrence of MR and future MR down the line. So we were able to put a third device on there. There's still some posterior prolapses you see, but there's much better control of the disease segments. And I think that means we're going to get a better long-term result. Nice reduction of MR and no significant gradient at the end of that case. Third, and just briefly, if you don't succeed at first, you've got to iterate and you've got to try again. And the TEER is very forgiving in that regard. So 74-year-old lady, surgical turn down, difficult anatomy with P3 disease, short leaflet, in the context of a diseased valve with bileaflet prolapse and a posterior leaflet of just 6 millimeters or so. First attempt, not medial enough. Second attempt, orientation wrong. Third attempt, severe medial MR. And this is the Pascal system where we could elongate, come out of the commissural part of the valve without getting caught, reset, think again, talk to our imaging partners and colleagues, work out what we're going to do differently. And that was a very safe, stable procedure with no issues. Fourth attempt, got it right. Good position deep in the commissure, good grasp, small medial residual jet, and a good basis for going on to put a second device on next to it, and subsequently achieving a nice result. This should be coming now with normalization of pulmonary vein flow and just mild, moderate residual MR. So, in summary, MitraClip and Pascal Precision are comparable TEER technologies with excellent safety profiles and efficacy outcomes. There are subtle distinctions in catheter and device design, but most patients, in my view, are treatable with both technologies. For complex valves, set the expectations up front, use the device you're most experienced with, plan the strategy, and manage the lab expectations and the team and what you're trying to achieve, and manage the patient expectations about what can be achieved with the technology we have. And finally, top tips for success: get the transeptal right, respect the valve planes, isolate the pathology where the valve area and gradient allows you to do so fully, and iterate for success. Thank you very much.
Okay, Tom, that was an excellent summary of technical considerations. I have to say this was awesome. Okay, so I think we can move on to a panel discussion. And Firas, we can start with you. Since you presented data on the two devices and Tom just went over an excellent overview of device selection, what's your practice? How do you decide between the two devices?
Yeah, this is a really important question, Tarun, that we face in in our daily life. Which patient for TEER and those who are for TEER, which devices. I think Tom did a wonderful illustration of some of the advantages of each one of those devices. I mean, I think in my practice, I find Pascal, to the last case that you've shown, Tom, was wonderful, is really able to go to the commissure, try one, try twice, and it is safe until you get the optimal results. I think the data have suggested that the results are durable, so that is a good sign. I mean, we look at the patients in their eyes and we say, if we get you good results, those results appear to be durable, and this is how my practice has been. It is about the ability to get MR reduction 1+ or less, and in many scenarios, that will choose what technology and what therapy to offer to the patients.
Thank you. Now, Tom, question for you is, you showed that beautiful case. You had a very generous mitral valve area. So you were able to put 3 devices and treat not just the color, but the disease also. What's your threshold for gradient, and how important is gradient in the trade-off between leaving residual disease segment or residual MR versus gradients?
It's a great question, and it's a really tricky question to answer, because what we know from the data is that both residual mitral regurgitation matters, and the lower the MR, the better, but also the gradient matters. And when you start to exceed and get significant gradients, there's a higher rate of heart failure hospitalization, and there's a worse long-term outcome. And that seems to be more the case in DMR than functional MR. Now, obviously, the best scenario is you have very little residual MR and you don't have very much gradient. Those people have the best outcome. But the situation you've alluded to is where you've got to try to trade off leaving some MR perhaps with causing a slightly high gradient than you might otherwise choose to accept. And I think the sorts of gradients that people talk about in the field, and there isn't very strong evidence for this, is sort of 5-6 millimeters of mercury mean. Now, the difficulty is that gradient is a very dynamic, movable thing. It depends on flow, it depends on heart rate, it depends on general anesthesia, and the gradient's typically 1-2 millimeters of mercury higher the next day. So even what you see in the lab is not necessarily what the patient's going to be walking around with. Where there's some comparison now of the relative trade-offs of MR and gradient, it appears to be the case that the lower the MR you can get, the better, even if that means leaving a slightly higher gradient. But I don't think we know where the cut points are for that. And perhaps gradient is not the right metric to be looking at anyway. Perhaps we should be thinking about mitral valve area. We need to be thinking about the context of the patient we're treating. What is that patient trying to achieve? Do they need to just potter around the house and go to the shops, or are they somebody who's much younger who needs much higher levels of exertion? But you've worked in this field. What's your take, and what do you guys do at Cedars?
So, we have become increasingly cognizant of the importance of residual mitral valve gradients. So we actually looked at the, we looked at the STS registry data, of all patients who underwent mitral clip for TEER in the United States for degenerative MR. We published that last year in JAMA. Very interesting. So we defined optimal success as mild residual MR or less, plus gradient of 5 or less. And we noticed in the mitral TEER space, we achieve optimal success in 60 to 65% of patients. And we defined procedural failure as greater than moderate MR and gradient greater than 10. So a fair number of patients are actually in that group of moderate MR with gradient less than 5 or mild MR with gradient between 5 to 10, which is frequent in our practice. And so the cutoff of 5 was a random number that was picked because that's supposed to be the definition for mitral stenosis, but we really don't know. And as you nicely pointed out, and then gradient is dynamic. What you see in the lab under anesthesia may not be the same case at day 1 under transthoracic. It may not be the same when patients are walking or ambulating. So it's a trade-off, but in our practice, we try to go for gradient less than 5, but of course, there are patients where you do see significant residual MR, and you accept a gradient of 6 or 7 in those patients at times for lack of another option. Firas, do you have any comments?
Yeah, this is a wonderful, question. I'll be honest. I totally agree with both of you in what you said. I think that especially in DMR, like our goal is to reduce MR. The worst nightmare are those who are left with significant MR and high gradients. I mean, I think by far those should not be, treated with TEER. And quite honestly, there are cases where you put one device and you still have moderate MR and a gradient of 8, and you try to move that device to different areas of the valve, because sometimes even subtle movement will make or subtle repositioning will make a difference in the gradient. But if you constantly are getting significant MR and significant gradient, then maybe this is a case to abort. I would say that we need to get better at predicting who those patients are. Sometimes we, get surprised, but I agree with your statement. Gradient does not tell the whole story. Gradient is extremely dynamic. And what I would say is I focus on the MR reduction. And the gradient is, as you've stated, sometimes is the cherry on top to celebrate success, or the warning sign to say, okay, you gotta abort.
Now, Firas, you're a high volume operator, and in the United States, there are several centers that offer mitral TEER, but not every center is as high volume as you are. So how do you suggest for physicians, for operators, programs, and cardiologists to improve referrals, or when should they refer and how to improve referrals?
Yeah, in fact, we looked at this, Tarun, and we published it based on the, the Medicare claims. But it seems like that, by average, obviously there is variation, geographic and operator variation, but on average, the operators are doing less than, 10 cases a year. So, so I agree with you that the majority of TEER is, and, somehow similar, story exists outside, TEER as well. But I think the message that I tell people is patients and physicians is that we have to thrive for good results. In fact, we have to thrive for MR 1+ or less. And I think that this is easier achieved in quote unquote the green category as it is in the yellow or the red. So many of the cases are done in the green category in the community, and they get good results. And I think those are really, good therapies. And we've known, and we've seen this, with Everest, we've seen it with the class 2D, both in the randomized and the registry. We've seen it with Expand, that those patients who get good results, the results are durable. Where it gets a little bit murky is, those complex anatomy. And I think that those we have to be a little bit careful with. And I think those are better served with centers that, not only high volume TEER, but also have, venues for other therapies like TMVR and high-risk surgery to get the patients the more optimal outcomes.
Now, Tom, I was going to ask this question, but you already showed a case. What do you think of commissural jets? But you showed a beautiful case of commissural jet where you were able to steer and get a perfect result. In your practice, are commissural flails or jets ever an exclusion straight up for the for mitral TEER?
I think in a lot of the patient selection questions come down to what are the possible alternatives to this patient. And we talked earlier about how good surgical repair can be. And if the patient has complex TEER anatomy and is a surgical candidate, I think the onus is on us as interventional cardiologists to say, look, this is complex for TEER. Surgery is going to provide a more certain or predictable, durable, perhaps, repair in this anatomy, and direct the patient to surgery as part of a single point of access or valve center where incorporating both ICs and surgeons. If the patient doesn't have a surgical option, okay, then it's somewhat simpler because it may be complex anatomy, it may even be near prohibitive anatomy. But if there's no alternative, then I think it becomes an easier conversation to have with the patient because TEER is safe, the risk of doing harm is very low. And so actually, I think in those situations, commissural pathology wouldn't put us off. And as we've already alluded to, I think in those sorts of situations, the Pascal device is maybe a little easier because it's so easy to get out from under the valve. And I can't ever think of a case where I've got seriously stuck under the valve with Pascal where I couldn't get out. And so that does make it a bit easier to have those conversations. But yeah, for sure, they're more challenging. What about you?
Yeah, I think with the availability of Pascal, the ability to elongate and safely steer under the mitral valve apparatus, the threshold we routinely do not think of commissural flails any different than any other flail. In our practice, they're very treatable, and you can try and fail and safely, steer out of the mitral valve without hurting the leaflets. If you don't get an optimal reduction despite multiple attempts. But honestly, we haven't encountered issues. That's been our practice. Firas, your practice?
Yeah, I mean, I agree. I also, want to say that we found, the precision system is also very helpful in achieving, the positions that you want. I mean, at least myself, I was very scared, when we started this journey of an unkeyed system. We lived, 10 years plus doing, using keyed system. And now, we had the whole freedom and I was like, okay, are we going to damage valves? What is that going to mean to us? I think further later, it got adopted in many, if not almost all the TMVR, systems, but also the ability to have, the unkeyed system, enable you to get exactly the device where you want it in the orientation that you want it in the trajectory, that you choose. It's easy to gain height. It is easy to be perpendicular to the mitral annulus on the AP dimension as well as the medial lateral direction. So all of that has increased the ability to precisely deploy the device where you want it.
Now we are running to the end of the hour. Great. We're running to the end of the hour. Now, this is last question for all three of us. We can start with you, Firas. If you had a crystal ball and you could look 10 years ahead of time, where do you see mitral TEER in the overall landscape of competing with surgical repair and TMVR and all these new and upcoming technologies?
Well, I mean, Tarun, I do not know, but every question you ask, I say, this is the brilliant questions. Okay, that from now on, they're going to be easier. And you somehow managed to make them harder and harder. I would say that, I believe that TEER is here to stay. I think that we are, expanding our comfort with TEER. We're increasing our confidence in the data. We are able to treat more complex anatomy. I do also believe that TMVR will have a role, and I do not think that the two are going to be, fighting on the same pie. I think there will always be patients that are not suitable for TEER. Dense MAC is and heavy circumferential MAC is definitely one of them. Some of the complex mitral anatomy is also one of them, and I think that those will probably be served with TMVR and will be complements. So I do believe that TEER is here to stay, to grow. And I think that TMVR will probably be added as a tool in our toolbox to to some of the MR patients. I do believe that the combination of two, and you showed this data from the Olmsted County beautifully. I hope that the combination of three, counting surgery and TEER and TMVR, will leave less and less patients untreated.
What does your crystal ball say?
I think that's absolutely right. It's going to be fascinating to see what the results of the studies ongoing in TEER versus surgery look like over both the initial period and the longer term follow-up. And I think we're going to have this question about whether the early hazard of surgery pays off over long-term follow-up. And that's going to be like a 5-10 year question that people are going to be asking. And then we're also going to start to see TMVR studies versus TEER in complex anatomies. And clearly there are TEER ineligible patients, but there's going to be a gray zone. And we're again going to be asking, is the early hazard of TMVR, does that pay off in some patients? Because there's going to be an increased bleeding risk. There's going to be a requirement for anticoagulation. There's likely to be a riskier procedure. TEER has just got so safe. So I think we're going to see expansion of TEER. We're going to see comparison of TEER in those two ends of the spectrum, the surgical end and the TMVR end. But and I think we're going to see evolution as well of the TEER devices, which are already extremely good. But I think there's iterations inbound which are going to make the procedure easier, more reproducible, and it's an exciting time.
Excellent. I agree with both of you. TEER is here to stay. If I were to summarize this session, which includes my opinion also, mitral TEER is safe. It is the safest therapy. It is effective. And with the improved device technology, patient selection, imaging, TEER is here to stay, and it'll enable us to continue treating patients. Now, I want to thank everyone at this point. That brings us to the end of the hour on management of degenerative MR with TEER and evidence-based guide. And as a reminder, this symposium is supported by an unrestricted grant from Edwards Lifesciences, and I'd like to thank our faculty, Firas, Zahr, and Cahill. And thank you for joining us, and goodbye, everyone.
Thank you.